Hello, everybody. Let me just bring up my PowerPoint. Okay. So my disorder that I chose to do this project on was obsessive compulsive personality disorder. So what is OCPD? According to the DSM-5, obsessive compulsive personality disorder is defined by a persuasive pattern of preoccupation with orderliness, perfectionism, and mental and interpersonal control at the expense of flexibility, openness, and efficiency, beginning by early adulthood and present in a variety of contexts. This personality disorder requires an individual to maintain extremely pristine and high standards in every aspect of their life. Extreme neatness, orderliness, fixation with lists and schedules, obsessions with perfectionism, and in some cases, hoarding behaviors are the most common that are seen. The difference between OCD and OCPD, OCD in the DSM-5 falls under obsessive compulsive disorder, obsessive compulsive and other related disorders, whereas OCPD is technically a personality disorder listed in the DSM. According to Barbara Van Noppen, people with OCD have insight, meaning they are aware that their unwanted thoughts are unreasonable, whereas people with OCPD think that their way is the right way or the best way, and usually feel uncomfortable with such self-imposed systems of rules. So basically, people with OCPD think that, are very stubborn when hearing other people's point of views or opinions. They're always in the right, and it's kind of their way or the highway. So history of OCPD. As it's known today, it was heavily influenced by Freud and his psychoanalytic findings. Freud described a triad of anal erotic characteristics. The three were orderliness, parsimony, and obstinacy, meaning stubbornness. And in 1908, Freud hypothesized that these characteristics were either sublimations of or reaction formations against anal erotic instincts of childhood. Later, in 1966, Carl Abrams put more emphasis on the demand for control as a fundamental aspect of these anal characteristics. And in one of my research articles, I found Samuels and Costa states that Abrams noted that individuals do not work well with others unless they are in control of the situation, which is a huge aspect of OCPD. If these people aren't in control, it's hard for them to follow orders of others or take directions from others. Obviously, these clinical descriptions eventually became known as obsessive compulsive personality disorder. And about 1 in 100 people in the US have OCPD, and it's diagnosed twice as much in men than it is in women. So the diagnostic criteria, I'll just go ahead and go over these straight from the DSM-5. A person with OCPD has to meet 4 or more of the following criteria. The first is preoccupied with details, lists, rules, order, organization, or schedules to the extent that the major point of the activity is lost. The second would be shows perfectionism that interferes with task completion. The third is excessively devoted to work and productivity to the exclusion of leisure activities and friendships. The fourth would be an overconscientious, scrupulous, and inflexible about matters of morality, ethics, or values. The fifth is unable to discard worn out or worthless objects even when they have no sentimental value. The sixth is reluctant to delegate tasks or work with others unless they submit exactly to his or her way of doing things. 7 is adopts miserly spending style towards both self and others. Money is viewed as something to be hoarded for future catastrophes. And the final one is shows rigidity and stubbornness. So basically these criterias 4 of them must be met in order to diagnose somebody properly with OCPD. So some risk factors here. The first is just simply being male, since it is diagnosed twice as more in men than women. A family history of OCPD or OCD is definitely a risk factor. There is a high degree of heritability here. I found that backgrounds of very harsh discipline in childhood can also increase your risk for developing OCPD. And also in some of the research indicated that being the oldest child in a family system can also become a risk factor. So diagnosing and assessment, this is a very hard disorder to diagnose in the sense that it gets overlooked a lot of the time. It gets clumped into the realm of OCD a lot, and people don't think to go outside of that box. Feinberg et al. State that there are no established rating instruments for assessing the severity of OCPD. Specifically, but structured clinical interviews are definitely the way to go for, assessing for the criteria necessary to meet the OCPD diagnosis. I found that the Compulsive Personality Assessment Scale is useful in a clinical setting. I found that in a couple research articles. It's made up of 8 screening questions to evaluate each of the DSM-5 criteria, which could definitely make assessment a little bit easier with a scale as this. Some self-reporting scales can also be used, such as the Obsessive Compulsive Personality Inventory and also the Multidimensional Perfectionism Scale. However, through my research, I have found that these scales have not been validated against the DSM-4 or 5, but not to say they wouldn't be helpful. Especially a self-report scale could be a useful tool to use with a client when trying to diagnose for OCPD. So differential diagnosis, differentiating OCD and OCPD is a big clinical challenge I kind of briefly discussed before. Feinberg et al. State that OCPD and OCD overlap in the expression of inflexible and stereotyped patterns of thinking and behavior, including in some cases preoccupation with orderliness, perfectionism, and scrupulosity, as well as behavioral or cognitive rigidity. Rigidity. I don't know how to say that word. The biggest difference to keep in mind between the two disorders is that for individuals with OCD, their obsessions and compulsions are undesirable and unwanted, like I've stated before. Whereas in OCPD, they are considered this ego-symptotic, and that their ways are considered desirable and correct. If you talk to a person with OCPD, there's nothing wrong with the way they're going about things. They're very, ego-focused. Their way's the right way, and they have a hard time, like I said, taking directions or following orders, especially if they disagree and with those directions. So for my case study client, his name is Bill. Made that up. So basically, I pulled from my case study all the DSM criteria that Bill met and the evidence to support it. So I'll just go through the criteria and then talk about how Bill meets that criteria. So the first was preoccupation with lists and organization. So my client, Bill, it's definitely evidenced by an uncontrollable need to make and keep daily or weekly to-do lists and schedules. My client in my case study writes multiple lists throughout the day, to-do lists, schedules, hourly, weekly lists and schedules, and it definitely on sticky notes or on index cards. So that's definitely a criteria for OCPD. Perfectionism interferes with task completion, and this is evidenced by compulsive need for perfectionism that interferes with work deadlines. Bill is known to do projects over and over again at work, which definitely gets him behind, and he does miss deadlines. But in his mind, he can't hand it in until it's absolutely perfect. But this definitely does get in the way of his, ability to complete tasks in a timely manner. Excessively devoted to work due to the exclusion of hobbies or friendships. So this is evidenced by Bill's lack of interpersonal relationships and leisurely activities. He does have a girlfriend of 5 years, and other than that, he doesn't report to having many friends. He doesn't report to having any sort of leisurely activities in his life or hobbies, due to constantly being focused on organization or work tasks or just completing things, his state of perfectionism. Another criteria is unable to throw out worthless items. So in this is evidenced by the excessive amounts of Post-it notes and index cards with the lists and schedules. These are kept all over his apartment in boxes, and Bill is not able to throw them out. He reports that he is afraid to throw out his old lists and schedules because what if he needs to go back and refer to one, or just he needs to know about what happened at a certain time, a certain day. And this is definitely getting in the way of some things in his relationship. His girlfriend reports to their apartment being very messy and overrun. There's index cards everywhere, and it's just becoming a problem. Another criteria is reluctant to delegate tasks or to work with others. This is becoming a problem for Bill at work, as evidenced by his inability to work with coworkers on projects and inability to take direction or criticism from boss or coworkers. Bill is having a hard time at work because recently he was asked to work on a project and a presentation with a couple coworkers, and his egocentric nature about and perfectionism qualities definitely got in the way, and it was not a successful experience for Bill, and it was very stressful. So the last one would be shows rigidity and stubbornness. So as evidenced by inability to see others' point of views, opinions, or reasoning, and as evidenced by by his attitude of him always being right. This shows through mostly in the work setting, but also in his relationship with his girlfriend. So let's move on to cultural and ethical considerations. Specifically for Bill, being an educated male is definitely a risk factor, as well as, cultural influence. I've did a lot of research and found that there's little to no evidence suggesting that cultural characteristics have any influence on whether or not OCPD develops in a person. Ulrich and Coyd found that little difference in the number of OCD traits by ethnicity, marital status, or social class. So there really wasn't too much to report on this. I did read that being educated could be a cultural, or ethical consideration to a greater chance of developing OCPD, since I did read one study that said college and people getting organized in college and even graduate school can kind of tend to lead to obsessive compulsive personality disorder type qualities, depending on your personality and your background and how you grew up. But other than that, not too much to report on this. So recommended treatments. Across the board, CBT treatment has proven to be helpful for people with OCPD. Wheaton and Pinto state that the cognitive approach to treating OCPD involves identifying and restructuring the dysfunctional thoughts underlying the maladaptive behaviors. So the whole idea of taking thoughts, thinking and linking them to behaviors and then going about changing those thoughts and behaviors is very helpful, since this is a very behavioral diagnosis, and it manifests in very behavioral ways throughout a person's life. And to move on, also behavioral therapies have shown to be highly successful among people with OCPD. Samuels and Costa state that behavioral therapy aims to increase adaptive and decrease maladaptive behavior patterns by using behavioral techniques such as graded exposure to increase the patient's reward and tolerance for novelty, increase emotional awareness and expression, and decrease avoidance tendencies. So behavioral therapy in the sense of like exposure therapy or, exposure techniques. So, for example, in Bill's situation, it may be exposing Bill to, a group project, or exposing Bill to a situation that would make him highly uncomfortable. These sort of behavioral things can help them sort of, recognize their current behavior patterns and then ultimately help to try and change those. So treatment plan, as far as Bill is concerned, the theories utilized in treatment with Bill, CBT, like I said, to help redirect Bill's process of thinking, also connected to the behaviors that come from that. Also behavioral therapies to expose Bill to stressful, anxiety-ridden situations, to begin to examine and explore reactions, and to begin to redirect some of those reactions. Also behavioral therapy to mock what it would look like to work with a partner, group, or team at work or elsewhere in life. So goals for treatment, client would like to purge through old lists and schedules he has kept over several years, and moving forward, challenge himself to only write one list per day. And then another client goal would be to become better at working on a team or with a group or partner. For these goals, some of the objectives here would be for the purging the list, obviously limit yourself. I would challenge Bill to limit himself to one list a day. Also challenge him to go through these old boxes of lists and, maybe get rid of one per week, or work on a system like that. And then as far as working on a team or with a partner, becoming better at that, maybe suggesting to Bill to join some sort of recreational team, softball, basketball, or, tennis, any sort of outside recreational activity. It might foster this environment where, learning to work with somebody on a team as a pair might become easier for him. So those are my thoughts there. And here are my references. And that is my presentation. Thank you all for watching.